Dear audience, welcome everyone. I am Benjámin Skribek from the Department of Oncoradiology. My supervisor is Ákos Pádeák, and we have a vision that minimally invasive therapies will be readily available solutions in the treatment of multiple diseases. Our mission that we would like to simplify the treatment of patients suffering from many various diseases, especially tumors. Our aim is to launch novel, humane, effective and safe techniques in Hungary. We have two ongoing projects. The first is investigating the efficacy and safety of minimally invasive interventions versus laparoscopy in the treatment of benign adrenal gland tumors. You can see that the prevalence of adrenal tumors are really low, but these tumors have many consequences. For example, if the tumors has a hormone-producing possibility, it can cause high blood pressure, hypokalemia, constipation, diabetes, and other organ failures. The gold standard therapy is laparoscopic adrenalectomy, but sometimes laparoscopic adrenalectomy cannot be applicable option. And it has relatively prolonged postoperative hospitalization, and it has prolonged operation time also, and has increased perioperative blood loss. We know many other therapeutic options, for example, interventional procedures like embolization, ablation procedures such as mechanical, chemical, mainly ethanol, and thermoablation procedures. These interventions have reduced interventional duration, it has decreased blood loss, and it has less postoperative hospitalization and has faster recovery after the procedure. Our aim is to compare laparoscopic adrenalectomy and minimally invasive interventions in the treatment of benign adrenal gland tumors. We have a clinical question that are minimally invasive interventions safer and more effective therapeutic options for patients with benign adrenal gland tumors than laparoscopic adrenalectomy. We use the PICO framework and we compared minimally invasive interventional procedures to laparoscopic adrenalectomy. Our main outcomes, the complication rate and the biochemical success rate. We have also secondary outcomes, for example, operation time, postoperative recovery, perioperative blood loss, and postoperative pain treatment. We have hypothesized that these interventional procedures are safer and more effective options than laparoscopy. We use the following search key, and we conducted the search in 5 databases. After the selection process, we had 5 eligible full text to analyze. Our first outcome is the complication rate. We can conclude that in terms of complications, excluding hypertensive crisis, the odds ratio is almost 1, so it has equal chances to have complications during these procedures. The second forest plot is in terms of hypertensive crisis. We can determine that during ablation procedures there is a 8 times higher chance to have this complication than laparoscopic adrenalectomy. And our third main outcome is the resolution of hypertension. The resolution of hypertension is more common in laparoscopic adrenalectomy. It is much more effective therapeutic option than ablation procedures. Our analysis have strengths and limitations also. The included articles have similar eligibility criteria, and we analyzed not only radiofrequency ablation procedures like the recently published meta-analysis. We included eternal ablation also. We used only comparative studies. We have limitations that these studies are all of them retrospective studies, and it has a low number of patients. And the studies focuses only aldosterone-producing tumors. So in conclusion, during ablation, we have a higher risk of hypertensive crisis with a lower biochemical effectiveness, but ablation procedures have shorter operation time and shorter hospital stay with a decreased perioperative blood loss. We have implications that laparoscopic adrenectomy is the most appropriate procedure, and it remains the gold standard therapy. And we have implication for research also that we need more comparative studies and mainly more RCTs to strengthen these results. We have finished the manuscript, and we have submitted to the Journal of International Journal of Surgery, which is a D1 journal. Our second topic is investigating efficacy and safety of minimally invasive interventions in the treatment of low intermediate risk prostate cancer. We can say that the second most commonly diagnosed cancer in men is the prostate cancer. Low intermediate risk prostate tumors is the stage 1 and stage 2 tumors, and these tumors are usually asymptomatic tumors. The first-line treatment is the radical prostatectomy and radiation therapy. But these therapies have many complications, for example, erectile dysfunction, total and stress, urinary incontinence, rectal injury, etc. We have also minimally invasive procedures to replace the first-line treatments. Thermoablation techniques, high-intensity focused ultrasound, irreversible electroporation, ultrasound ablation, targeted photodynamic therapy. Our aim is to find the most appropriate interventional therapy for the treatment of low intermediate risk prostate tumors. Our question: which interventional procedure is the safest and most effective option for patients with low intermediate risk prostate tumors? We would like to compare these interventional procedures with each other, and we have the main outcomes is the complication rate, progression-free survival, and recurrence rate. We hypothesized that by comparing these different intervention procedures, we can determine which is the safest and most effective therapy. We use this systematic search key, and we conducted this search in 3 databases. We finished the selection process, and we had 98 full eligible articles. You can see that we found most of the articles including HIFU, irreversible electroporation, and cryoablation. And we have only 6 comparative studies which are compare HIFU with cryoablation. We have only a few articles about microwave ablation and radiofrequency ablation and embolization, so we had to exclude these articles. So we finished the selection process, and we would like to start the data extraction in the near future. And you can see my ongoing project, and thank you for your attention. And I would like to close my speech about Benjamin Franklin words: tell me and I forget, teach me and I remember, involve me and I learn. Thank you so much.
Thank you so much. Nice presentation. I have one question. I would like to ask that which group of patients do you recommend mostly the minimal invasive intervention in case of the adrenal gland tumors?
Yes, it's a good question, thank you. I mentioned that laparoscopic adrenotomy not always applicable, but I don't mention which conditions. LA is not applicable if patients has extreme obesity or have anemia or cardiopulmonary diseases, and if the patient has previous surgical therapies, sometimes it can be a contraindication to have a laparoscopic adrenotomy, and minimally invasive interventional procedures are in favor.
Yes,
Thank
please.
you for your presentation. I'm just asking about what is the definition? Was it the same for hypertensive crisis? And what do you think was the cause of the big difference between the two groups?
The complication rates and the hypertensive
The hypertensive crisis is the odds is 8 times higher in the RSA group.
Yes, because during ablation procedures, we can easily hurt the vascular system of adrenal gland, and it can cause the hypertensive crisis. The complication rates I mentioned in the first figure, it shows the minor and major complications, which is in the eligibility criteria in the articles. These complications are mostly cardiac complications, bleeding complications, respiratory complications. For example, PTX can be a major complication of these procedures. And we wanted to separate hypertensive crisis because this is the most common complication under these procedures, and we did not want to mix the other complications. This is the cause we separate the complication rates and the hypertensive crisis.